Aibovan, and a very good evening to all our viewers here on TV1. I'm Dr. Dilshan Fernando, and this is your weekly dose of wellness here on Healthline. And a warm welcome to all our viewers joining in via YouTube as well. Today we have a young neurosurgeon joining us here in the studios. He is doing some exciting things for the first time in Sri Lanka. So we have invited him to the studios here today, and we'll be talking about brain tumors. Our guest this evening is Dr. Chula Kanishka Anandala. He is consultant neurosurgeon at the National Hospital in Kandy. Very good evening to you, sir, and thank you very much for joining us here on Healthline.
Good evening, Dilshan. Thanks for inviting me.
Of course, it's a pleasure to have you, sir. Now, as we said, our topic of discussion today is about brain tumors.
Yeah.
So, as an introduction to our program, if you can tell us, what are these brain tumors and are there various different types?
Yeah. I think actually best thing to start the discussion is with the recognition of what a brain tumor is.
Sure.
Particularly the reason is we neurosurgeons as a bit of a obstacle when we deal with patients in our clinical practice, because our patients' perception about brain tumors is a little bit different, and I must say it's not very satisfactory.
Okay.
Particularly when I compare it with how people in developed world look at brain tumors. We need a little bit of more understanding from our general public. Sometimes when patient comes to our clinic with the diagnosis of brain tumor, they are sometimes really depressed, and I have had few instances where I had to send the patient for a psychiatric assessment because they were having suicidal thoughts.
So they think it's the end of the
exactly.
journey for them.
So our people think when there's a brain tumor, okay, I have a brain cancer, I'm going to die, and my family is destroyed, and this is the end of the story. This perception needs to be changed, because one of the fundamental principles of managing any disease is to get the psychological status in a very stable situation to begin with. So if I am to introduce what a brain tumor is, it's basically excessive abnormal growth of brain cells. This is the definition for any tumor. As we are concentrating on brain tumors, that's the simple non-technical introduction. Other thing is, when we say brain tumors, that's the general word we use, but that includes all the tumors that we see inside the cranial cavity, inside the skull. And not all of them are brain tumors, because ideally when we say brain tumors, the tumor should arise from the brain tissue itself. But we have quite a lot of tumors which arises from other tissues inside the cranial cavity. Like we have brain coverings which we call meninges, you can have tumors from that. We have blood vessels, and the brain is having a fluid filled cavity, and there's a lining in it. We can have tumors from there, and we can have tumors actually coming from the bone. So all these tumors can appear inside the cranial cavity, and the general lay term for all these pathologies is just brain tumor.
Yeah.
But public should know, when someone say brain tumor, it may not be really from the brain itself. And sometimes you see the brain tumor is actually coming from somewhere else. The primary tumor is somewhere else,
so
and you get a secondary deposit in the brain. We still refer that as a brain tumor. Two categories we recognize here based on that is primary brain tumors and secondary brain tumors. When I say primary brain tumor, that has arise from the structures within the cranial cavity, either brain tissues itself or other supporting structures. When I say secondary brain tumors, the primary tumor is actually somewhere else, and you have got a secondary deposit in the cranial cavity. That is basically the introduction, and this bit of a details need to be among general public for their better perception. And just because of its abnormal excessive growth of cells doesn't mean that the patient is going to die. We have different strategies of management, and if the patient change their perception towards brain tumors, we can start the management from that point onwards.
Now, to continue with our discussion, sir,
Yeah.
now we introduce what these brain tumors are, the primary ones and the secondary ones. So, in your practice as a neurosurgeon, do you see this very commonly? Is it common presentation to you?
Well, yes. Now, the problem is you are referring to epidemiology basically.
Yes.
There are quite a lot of studies where the worldwide global statistics are discussed, but if you look at the literature, there's extreme variability, as you see. Unfortunately, we don't have any formal data among Sri Lankan people, but in a sort of summary, if you want me to tell, no one is protected from brain tumors. Anyone is vulnerable to get brain tumors. Recent UK data analysis says everyone carries 1 to 2% of risk of getting a brain tumor in their lifetime. I'm not quite sure about that figure, but that means everyone is at risk. And every age is affected, and both genders are affected, and there are variations, of course, based on the age group and the gender, but still everyone is vulnerable. If you really want me to come up with some figures, there are certain figures which are definitive because those are constant in most of the literature. This is related to malignant brain tumors, that's cancers. Generally, it says there's 3.7 per 100,000 population.
This is the
global scenario in male, and 2.6 per 100,000 population in female. So there's a little bit of less value for females. Of course, benign, when it comes to benign, I think the ratio reverse, but I'm not quite sure about the exact figures. So what I can say is everyone is at risk of developing brain cancers, and for Sri Lanka we don't have any clear data as such. Yeah.
So you partially answered my next question, because when we say brain tumors, people tend to think that all of them are cancerous.
Exactly.
But of course, like you said, there are benign ones and the cancerous ones.
Exactly.
So let's, if you can elaborate a bit about which types are more common and what are the, like now you said everyone is at risk.
Yeah.
So after you describe about these benign ones and the cancer ones, can we discuss a bit about what these risk factors are for developing these tumors?
Exactly. Now I said basically we have this primary brain tumors and secondary brain tumors. One of the important reasons why we need to differentiate whether it's primary or secondary at the beginning itself, the primary brain tumors, the whole spectrum is there from very benign to very malignant. Very benign means very innocent one, slow growing, it doesn't invade into normal brain tissues, and when it comes to management, we can wait, we can take time for interventions. Whereas the other spectrum is highly aggressive tumors, extremely malignant ones. We need to do something very urgently, otherwise it's spread all over the brain. So in primary brain tumors, we recognize the whole spectrum, but when it comes to secondary brain tumors, almost all the time those are malignant. How they have got the secondaries, because there's a primary somewhere else. One of the important pathological properties of a cancer is the spread. That is how they have got it in the brain. So if someone is diagnosed to have a secondary brain tumor, it's almost always a malignancy. Then going into your next question, the risk factors. Of course, I think even in other other medical disciplines, when they talk about tumors, always they talk about risk factors. The reason is that is how you aimed at preventing, getting these tumors. Because if you know risk factors, you can take necessary actions to prevent. The problem is when it comes to brain tumors, unfortunately, not much of risk factors are very well established. There are quite a lot of clinical and experimental studies going on to find out what those risk factors are, but unfortunately, at the moment, if you compare it with tumors in other organs, the brain tumors still are etiology-less.
Right. So
we don't really know.
No clear-cut risk factors.
But going into detail, because it's an important area to discuss, there are two main risk factors well established, recognized. There are so many clinical and experimental evidence to say those have causative relationship to brain tumors. That is, one is ionizing radiation, and the other one is genetic mutations. I want to mention a little bit about this because patient always ask this.
Of course.
Ionizing radiation means the radiation that you get with X-rays, CT scans and things. This ionizing radiation has the proper ability to damage genetic materials, DNA and stuff. That's the fundamental etiological process of beginning of a tumor. And this is well recognized in clinical practice. Even I have met few patients during the childhood, they have undergone irradiation for some other pathology like leukemia, lymphoma. In adulthood, when they are in their 30s and 40s, they come with brain tumors, particularly meningiomas and gliomas. And epidemiological data and the clinical data and even experimental data in animal studies have proven the ionizing radiation can lead to these tumors. So, that is one thing that we know. Right. Then a little bit about non-ionizing radiation, again because patients ask about this. Non-ionizing radiation is the electromagnetic, basically what you encounter during MRI scans. Because sometimes patients ask, is it okay to undergo an MRI, because people, I mean, they are a bit aware that CT scan is a bit risky. If you look at clinical and experimental data, we are not very convinced yet that electromagnetic waves has got any carcinogenic property. So, it's safe. And the other question patients always ask, not always, some people have this concern about the mobile phones. Radio waves.
Yes.
This, of course, at the moment we don't have any conclusive evidence, and there are studies going on, but there are epidemiological studies saying that if you frequently use mobile phones, you are vulnerable to get tumors like acoustic neuromas, vestibular schwannomas and temporal lobe gliomas. There is clear epidemiological association, but none of the clinical and experimental studies have not shown this.
Proven yet.
Yeah. So, best thing, I don't know how we can avoid using mobile phones today,
exactly. Yeah.
But that is suspicious area. But MRI is it's safe because electromagnetic wave has no causative relationship.
Right. But now viewers might be a little bit alarmed when you say this radiation with regards to X-rays and CT scans, because these are common investigations that we use. So, if you can just elaborate, is it is there a risk involved with just getting one X-ray or one CT scan, or is it a series of X-rays and repeated exposure to radiation?
This particular carcinogenicity risk is dose dependent. If the radiation dose is very little, the risk is minimum. So, I would say in clinical setup we do X-rays, but the dose of radiation is very, very low. And I don't think we need to think about getting, restricting X-rays just because of we want to prevent someone getting brain tumors. Yes. CTs, of course, there's a higher level of radiation, but still I think unless you are repeatedly exposed to CT radiation, or unless you are exposed during childhood, because childhood, the brain supporting cells are very active, they're dividing, so they are more vulnerable to get damaged by radiation. Then of course there is a risk theoretically as well as it's clinically and experimentally proven. So, we need to be little alert when we repeatedly request CT scans, but of course we have to always balance risks and benefits. If the benefits are more in doing a CT scan, I don't think we should restrict doing it just because of the risk of getting a brain tumor.
Definitely. Now, that is one important thing that we want to reiterate. Even though ionizing radiation or radiation involved with X-rays and CT scans are a risk factor for these brain tumors, clinicians, of course, like Dr. Chula said, weigh the risk-benefit balance. Only if the benefit from doing this investigation outweighs the risk, only they will go forward. So, always go with the judgment of your clinician involving any other condition as well, because we know X-rays and CT scans are common day-to-day investigations that we do. Now, when a patient presents to you, sir, what are the symptom profile? We know that brain is a very complex organ. It's basically the control room for the entire body.
Yeah, exactly.
So, depending on the position, of course, of the tumor, the symptoms may vary. But what kind of symptom profile do you see in your day-to-day practice?
Before going into this, I just need to mention few things, because
Yes.
then it will be easier for us to discuss about presentation.
Of course.
When it comes to brain tumors, the whole spectrum of pathophysiology is little different from what you see in other organs. The fundamental reason for this is the brain is covered with the skull, which is a rigid non-expansile structure, whereas when it comes to other organs, it can expand. So what happens when there's a brain tumor? The tumor occupy a certain space inside the brain. As the skull cannot expand, it increases the pressure. Now this is the biggest problem that the neurosurgeons face, because sometimes actually the clinically significant problem is not the tumor itself, it's the increased pressure. Of course, that's one thing. Other thing is the brain tumor can invade and destruct normal brain tissue, and the brain tumor can invade and destruct blood vessels, which will compromise the blood supply to the brain. And of course, the tumor can compress the water fluid pathways inside the brain, causing accumulation of the fluid. So all these mechanisms can give rise to different types of symptoms and signs. So moving into the clinical presentation, unfortunately, when it comes to brain tumors, most of the common clinical symptoms and signs are very non-specific. Just by just because a patient has got these clinical symptoms signs, we can't say definitely the patient has got a brain tumor. It needs further analysis, but we need to be aware of these things, then only we can suspect.
Definitely.
A few things I should mention. One thing is the headache. I think most of our patients, if you analyze the symptom profile, most of them presents with headaches, sometimes associated with other features too, but headache is very commonly encountered. Unfortunately, headache is encountered in most of the conditions. You can't really say the patient has got a brain tumor
just because they have
exactly. So what we do is we go into details and see if there are any red flags associated with the headaches. As a message to the public, I can say if an adult person has got a new onset headache lasting for few weeks, more than 2 or 3 weeks, that's a very alarming. That's a red flag. And not all of them have got brain tumors, but in that case, we need to investigate and see if it is a brain tumor. And the other important red flag associated with the headache is if the patient is getting the headache in the early morning with sometimes nausea and sometimes actually vomiting, and after vomiting patient feels better, headache goes away, and that's a feature of increased intracranial pressure, may well be secondary to a brain tumor. Now these two things I think the general public needs to be aware of, because I have had cases where these presentations are very clear, have been there for a very long time, sometimes several months, 6 months, sometimes even 1 year in certain benign tumors, and the patient comes much later, and at that time the disease is very advanced. So those two red flags associated with the headaches needs to be thought of. Then of course, if a patient has got any neurological deficits such as visual impairment, hearing impairment, sensory deficits. Recently I got a patient who is an electrician and he thought he is getting electrocuted frequently, but it's actually a brain tumor.
So he was having tremors, is it?
He was sort of getting a sensation of electrocution, lightning kind of a sensation. Right. So he thought it's
associated with his occupation.
So, exactly. Sometime motor weakness, hand weakness, leg weakness, things like that. So all these neurological deficits needs imaging. Because it may not all of them have got tumors, but we need to look into. Then there's another group of patients presenting with collapse or convulsions, loss of consciousness. That's again particularly because of increased intracranial pressure, but it may be because of the tumor location also. Patients who have got tumors in brain stem area can present with alteration of consciousness and collapse and things like that. So all of them need imaging to see if there's a brain tumor. Then other important categories, particularly in adults, if they develop a recent memory loss and some kind of a psychiatric illness, behavioral changes, things like that. Again, we always think about medical condition, but it may well be a neurosurgical condition, brain tumor. I mean, we have got patients who are being followed up at psychiatric clinics for years and years. They have been on psychiatric medications for depression, bipolar affective disorder, schizophrenia, and for some other reason they come for imaging, and when we do the imaging only we find a brain tumor. And surprisingly, when we take out the brain tumor, they are completely cleared of their psychiatric illness. So those are the clinical presentations. There's another category I just want to mention because it's quite common these days, because there are non-neurosurgical reasons why we go for brain imaging, sometimes for evaluation of medical conditions, stroke related presentation and things, and you might find a tumor which is not actually related to his presentation, which we call incidentally detected brain tumors. That group is also important because brain imaging is quite common today, and we are getting quite a lot of patients to clinic coming with incidentally detected ones. Not all of them needs treatments, but they need a bit of a surveillance. We need to do repeat imaging to see if there's any effect on the brain, but otherwise we don't have to do, because that is not the cause of their illness.
So no active treatment is
no active treatments really needed, but they get upset. They are sometimes psychologically depressed, thinking that they have got a brain tumor. So we need to address it, but not all of them need active treatment. So those are basically presentations of neurosurgical patients with tumors.
Definitely. Now there is very important information coming from Dr. Chula. Like he said, headache, a new onset headache in an adult which lasts for more than about 2 weeks, or if you have an early morning headache, and with that headache if you vomit, if you have a sense of nausea, and then if the headache relieves, that is definitely a red flag sign that you should be followed up by your properly qualified medical practitioner. And also any weakness in your limbs, or if you have any behavioral changes. Before we make a diagnosis of any psychiatric illness, neurosurgical condition may need to be excluded. Now you repeatedly spoke of these imaging, sir.
Yeah.
Now if a patient presents to you with one or more of these symptoms, what form of imaging would you be employing, and can we get a definitive diagnosis from this imaging?
Yeah, so basically we are moving into the diagnosis of brain tumors. There's one thing that I want to mention. Now all these clinical symptoms and signs, I said it's very non-specific. So I think a general public should know to go to a general physician or qualified medical officer for the first assessment. Yes. If they start running into neurosurgeon, it's a bit difficult.
Then you will have too much of work to
neurosurgeons will not be able to do anything else, because I mean, if you think about headache, it's such a common thing, and not all the headaches should come to a neurosurgeon.
Definitely.
So they should go to a qualified medical officer, and then they will do the basic assessment, and they will exclude other conditions. There are two ways. One thing is, if they really think that the patient needs a neurosurgical opinion, they can refer the patient to us, or else in our country qualified medical officers can actually request brain imaging like CT scan. So they can do it. If they find something, they can refer the patient to us. So basically the diagnosis of brain tumors are based on imaging. Fundamentally we still do CT scans to begin with, because it's the cost is less and it's available. It's available in government sector. So we do that, but the recommendation is always to confirm it with the MRI scan, because it has a better resolution to give more details. And I don't think in the standard practice of medicine we should always go for MRI scan before treating brain tumors. Unfortunately, in our settings, MRI is not readily available always, and sometimes we have to even operate based on CT findings. But MRI is the
gold standard?
Gold standard. I would say gold standard practically to diagnose a brain tumor and even to plan the surgical interventions. There are other modalities of imaging which is needed in specific cases, but not all the patients need it, such as angiograms, and you might have heard of this functional MRI. So there are other investigations for certain cases, but MRI is ideal enough. Then of course in some of the cases MRI also comes as inconclusive. Unless the pathology is very clear, we can't go for a surgical intervention. In those patients, we go for what we call biopsy procedure. It's a less invasive surgery. We take a little bit from the tumor and send it for laboratory analysis. Then the pathologist can say if it is a brain tumor or not. So basically it's CT, MRI, biopsy. Those are the diagnostic modalities available, but most of the time, nearly 70 to 80% of the time, it's just the MRI.
Now, let's say we have a patient with those symptom profile. You have done the imaging, you have found some form of tumor.
Yeah.
What are the considerations when moving forward to possible treatment?
Yeah, again important area to discuss. Particularly, we have few messages to give to public. Once the brain tumor diagnosis is made, it does not mean all of them are going to undergo a surgical procedure to take the tumor out, because there are different modalities of treatment. Of course, commonly it's surgery. Mainstay of for any tumor, the main treatment modality is surgery. But we have things like radiotherapy, chemotherapy, and sometimes we don't have to do anything actually. We just have to keep the patient under surveillance with repeated imaging to see if there's any need of any interventions. The important message to public here is this is one of the common problem that we face, all the neurosurgeons face in clinical practice. The moment a patient is diagnosed with a brain tumor, they just want to take the tumor out.
Exactly.
To be honest, I didn't see this very commonly in my practice in UK, but here every single patient wants that. Particularly, I said that group of patients who come with incidentally detected brain tumors, generally we don't have to do anything because their illness is not because of the tumor. And if the tumor characteristics says it's a very innocent, slow growing tumor without any effect on the brain, we don't have to do anything. Why we need to avoid doing things in relation to brain surgery is brain surgery it carries risk. There is no brain surgical procedure without any risk. So unless it's really, really needed, we don't have to jump and do a surgery. So what I want to tell first is, if the neurosurgeon has gone through all the details and decided that the patient does not need a neurosurgical procedure at that particular moment, of course patients can, they can take time to think, they can take a second or third opinion, doesn't matter. But they needs to be little aware of this particular situation too. It may be really not necessary, so there's no point in sort of forcing for insisting on a surgery because it might cause more harm than good. Then let's say we have decided to do surgery. Now when we decide to do surgery, again I said as the brain surgery is not very simple, it carries its own risks. It can even be life-threatening, and sometimes surgery can kill the patient, not the tumor. So we need to always balance risks and benefits. Basically, the benefits are, of course, taking out the pathology from the brain, and then preventing the progression of neurological deficits or preventing any new neurological deficit appearing, and sometimes it's just life-saving. Risks are, of course, it can be life-threatening, and it can damage normal brain, which gives rise to new neurological deficit, or maybe a progression or worsening of existing neurological deficit. So neurosurgeon will balance risks and benefits and say, okay, let's go for surgery or let's not do the surgery. So if the neurosurgeon say we need to do the surgery, again patient has the right to decide, and it can take time. They can go for second or third opinion, doesn't matter. But they need to be aware of this situation because surgeon has given this option of surgery because it's really needed at that particular stage. In our population, I have encountered this several times. The patient wants to take some time, they want to go for opinion. As that is patient's right, we just allow. But patient comes sometimes 6 months later,
and the disease has progressed.
Exactly, but I have to tell very clearly, I am not going to offer the surgery directly just because of patient is appearing for the second time, because at that stage the disease may have completely changed and now the surgery may not be the option, the best option. So I have to re-evaluate the patient and probably we need to
redo all the
imaging to see if it is operable. And I'm sad to say I have had several instances where a patient comes much later and the repeat assessment says the tumor is not operable, particularly in malignant conditions, brain cancers. The public needs to be a bit aware of this. They can take some time, but they can wait so long if the neurosurgeon has suggested surgery as the best option. Then moving to the other category, that is if the surgeon has decided not to do the surgery, that is because of either surgery is not necessary or doing surgery causes more harm than good. That is also important because there is no point in doing a surgery and taking the tumor out if the patient is not going to have a quality life, isn't it? We always look for quality life in today's medicine, evidence-based practice. That is what our aim is. We don't need the patient who is not conscious, fully bed-bound, totally dependent, what we call the vegetative stage. That is not our objective of a surgery. We need to have a person with acceptable level of mobility and quality of life. So if the surgeon thinks the patient is not going to get that, of course he will say the surgery is not the best option. There may be other options like radiotherapy, chemotherapy to control the disease. That also public needs to be aware of, because there's no point in sort of insisting on that on surgery, because it's going to cause more harm, and if we ended up having such patient, it will be a burden for the patient himself, and it's a burden for the society, it's a burden for the health system. So that's also important message that I want to give.
Definitely. Now neurosurgery is no simple matter. It's a very complex procedure, and the decision whether to go in for surgery is definitely with a complex series of investigations, with the expertise and experience gained by these neurosurgeons. So like Dr. Chula Kanishka just explained to us, the decision to go for surgery or not is a very specialized expert opinion, and that decision stands to hold true for that moment only. If you take a long period of time to get another opinion, to make up your mind, go around and do more investigations, the situation may change, especially with regards to malignant disease, because it keeps on progressing and the outcomes of surgery may not be the same as decided previously. And also, like Dr. Chula said, active surveillance especially in incidental findings is an accepted modality of treatment nowadays, because whatever symptoms that you're facing is not particularly due to that tumor. So actively monitoring that and seeing whether it's growing, whether it's causing any damage to the brain is always acceptable, because why we say this is we know that the Sri Lankan population tends to look for quick fixes, especially if you feel, you know that you're harboring some form of tumor. Always getting rid of it is not always the best option. So all these decisions need to be made with your neurosurgeon and not particularly by yourself, even though you definitely have a say in this. Now, sir, we know when we talk about neurosurgery, we said we are doing some exciting new things. So you're doing what we call awake neurosurgery. So what is this? This is a new concept to Sri Lanka, and
it's pretty much new to us, but it's a very well established management strategy in developed countries. And just one thing, I'm not the first one to do this. There are few people who have already done that, but I think we don't have this setup to do it regularly in our centers. That's the problem. But I'm trying to do it regularly now. Awake surgery now. Now I said, now when we operate on brain tumors, we always go for risk reduction strategies, that is to prevent any damage to normal brain which is just sitting next to the tumor. There are so many techniques available, like MRI based navigation to locate the tumor, then intraoperative ultrasonography to locate the tumor, and sometimes we use dyes and fluorescent materials which will tell us this is the tumor, this is the normal brain. sometimes we use neurophysiological monitoring, things like that. Awake surgery is another technique, risk reduction strategy to get rid of the possibility of normal brain damage. Though we tell it's awake surgery, patient is not going to be awake throughout the surgery. When we take out the tumor, only the patient is awake, and we communicate with the patient. We give certain tasks to perform, and we can recognize if there are any disability developing when we take the tumor out. Now, important thing is, let's say we go on doing the surgery, communicating to the patient, and at some point we detect patient is developing some kind of a disability, then we have to stop doing the surgery, which means there's little chance that we might not be able to take the whole tumor out. Patients needs to be aware of this. If they have given the consent to go for a big surgery, we need to be clear that there is some possibility that there's a residual tumor after the surgery. It's not a big problem in very slow growing benign very low grade tumors, because either we can keep the patient under surveillance to see if it is growing further, or we can send the patient to other alternative treatment strategies like radiotherapy, which helps. Fortunately, these awake surgeries are very commonly performed for very low grade tumors in young patients, and when the tumor is located in relation to a very eloquent important area of the brain, such as area of the brain which controls movements, area of the brain which controls speech and things like that. And these low grade tumors are commonly encountered in young, particularly male patients. So it's very, I think it's important for us not to make a young male patient disabled for the whole life, because doing a awake surgery, even if we keep a little bit of a low grade tumor, patient might survive without any deficit for another 10 years or at least 5 years. And we have always other option of management. We can redo surgery later, but patient will still live a normal life. I have encountered patients living for more than 10 years without very low grade, with low grade tumors who have undergone awake surgeries. The important message is this particular technique of surgery is not suitable for all the patients. We decide based on patient characteristics and disease characteristics. So only a selected number of patients are suitable for this, and I have found it's very, very worthy for that particular group of patients, because patients go home and start doing their day-to-day work, occupation without any disability after awake surgery.
So now the question arises, especially to our public, when you say awake surgery, while you're doing this procedure, do they feel pain?
That's the important thing. So neurosurgeons are very rarely lucky, but in this particular instance, neurosurgeons are very lucky because other organs has got pain perception. But when it comes to brain tissue itself, there is no pain perception. This is the fundamental principle based on we employ this particular strategy. We can handle the brain while the patient is awake. There are no pain perception receptors in the brain, so they don't feel pain.
So initially, to gain access to the brain,
we give some local anesthesia to skin and sometimes to the dura, but the brain itself does not need any method to get rid of pain because it doesn't perceive pain.
Right. Now, after a patient has undergone brain surgery, we know that it is one of the most complex surgeries around. So, what is the post-operative experience that they can expect? What kind of hospital stay and what kind of rehabilitation process can they expect?
This is another important public message, because brain surgery recovery is different from recovery from surgeries of the other organs. Particularly this because in adult neurons does not grow. It's an inherent property of nerve cells. Other supporting structures can grow to a limited extent. Because of this, the recovery after surgery can take very, very long time. Sometime in months, sometime it might take 1 or 2 years, because the functional recovery may be there can be a little bit of synaptic reconnections, rewirings in simple words, which brings back the functions, and sometimes other brain parts start performing the loss function. So things, the mechanisms are there, but those are very, very slow. It's time taking. So you can't expect immediate recovery in all the neurosurgical patients. There are instances where patient immediately improve, but there are quite a lot of instances where it takes sometime months, sometime years. So during the discussion before the surgery, we always tell this to the patient, and they are generally aware of this. So they need to carry out things like physiotherapy, occupational therapy, sometimes psychological rehabilitation and things for them to come back to their normal state. And other important things, unfortunately, in certain cases, the functional recovery may not be 100% complete. They may not be able to go back to the
way they were before.
Exactly. But still, I said we balance risks and benefits. Because of benefits are more, only we have done the surgery. So public needs to be aware of this particular situation too, because we have done the surgery because of there is some chance for the patient for better survival.
Now, we spoke about delayed presentations, and we spoke about how certain patients have come to you with delayed, very advanced brain tumor. So, and some people may be very anxious and scared of getting these brain surgeries done, especially because of its complexity. Now, just as a message to our public, sir, if a tumor is not operated within the given period of time, what kind of possible complications may occur in these patients?
This actually depends on whether the tumor is a malignant one or a benign one, and then the location. Malignant tumors located very close proximity to eloquent areas of the brain, important areas of the brain, going to progress, and once it invade that particular area of the brain, complete excision of the tumor is not possible, and they can get either temporary or permanent neurological deficits such as weaknesses, blindness, hearing deficits, sometimes personality problems, memory problems and things. In malignant tumors, this is quite fast. That is why we always try to implement all the management strategies pretty early. Benign ones, delayed presentation is not a very big issue, but if the delay is very, very significant, unfortunately some people with benign tumors present to the clinics for the second time 5 years later, sometime 10 years later. They have carried out their day-to-day work with sometime disability. I think there is some degree of anxiety also to undergo neurosurgery among the public.
Exactly.
So benign tumors, again, if you take a very long time, it can cause quite a lot of disastrous complication. Particularly, it may well be sort of destroying the normal brain tissue and sometimes compromising the blood vessel to normal brain, sometimes blockage of the water pathways leading to increased intracranial pressure. All these things can happen even with benign ones. So the message is you should not postpone malignant ones. You can postpone benign ones, but not to a massive extent.
Within a reasonable period of time.
So, because complications can be very disastrous.
Definitely.
And it may not be possible for us to do anything even for a benign one.
Exactly. Now, with the time constraints that we have, we are coming towards the end of this edition of Healthline. Before we wind up, sir, what would be your message that you want to convey to our public? Even though brain tumors are not very common, like you said, everyone is at risk. So what is your message to our public?
Few important things. One thing is we need to change our perception on brain tumors. Just because of you have a brain tumor doesn't mean that's the end of the story. We can treat it, you can go back to near normal life, and even with a disability, it may well be an acceptable level of disability, and you can still carry out certain tasks. So we should get rid of this idea of bad impression on having a brain tumor. And we have qualified trained neurosurgeons now. Unfortunately, we have only 20 neurosurgeons for nearly 22 million. So we are extremely busy. So the next message for the public is, if a neurosurgeon has offered the option of surgery, don't delay it, because delaying it cause a lot of problems. One thing, it's not good for the patient himself, because the disease stage, as we told, it may be very well advanced by the time the patient present for the second time. And the other thing is, our waiting list are very, very big. Some people wait 6 months, 1 year, and if we have suggested early surgery and the patient does not come to the surgery, it compromises someone else's opportunity who is waiting in the list. So my message is, change your perception on brain tumors, and if the surgical option is given, accept it. You can discuss, you can take time, you can take second opinion, third opinion, but be aware of this particular situation where delays can cause problems to the patient himself, as well as to others, and even to the health system.
Definitely. Now, it was a very interesting conversation today here on Healthline about brain tumors and the possible treatment modalities available. Especially Dr. Chula has given us food for thought and how to change the perception about brain tumors. Even if you're harboring a brain tumor, it doesn't mean that it's the end of the road for you. So, because of this conversation, I'm sure you may be able to revisit your perceptions, rethink, and if we touch certain lives, that is our objective, to spread the word, to educate the public. So we thank Dr. Chula Kanishka Anandala, consultant neurosurgeon. Thank you very much, sir, for your presence here today and for this very interesting discussion. Thank you once again.
Thank you very much, and I wish you all the very best for your future programs.
Thank you, sir. And with that message, we take your leave and wind up for this edition of Healthline. Until we meet you again next week with your weekly dose of wellness, I'm Dr. Dilshan Fernando, wishing all our viewers Aibowan.